Justine, and then at Texas Children's Hospital, Bayer College of Medicine. And she is clinical assistant professor in the Department of Radiology, Radio-Oncology, and Nuclear Medicine at the University of Montreal. She's the author or co-author of 4 book chapters, multiple peer-reviewed articles, and research abstracts. And we are really, really glad that she's going to speak on something which is an extremely important topic and something I hold close to my heart, the pediatric lungs. And I also want to acknowledge and appreciate the Society of Thoracic Radiology, who is essentially taking this session in collaboration with us. The STR does once a month collaborative sessions on thoracic radiology with us, and Dr. Julie is part of this collaborative session. So thank you so much, Julie, for agreeing to take this session. We're looking forward to the talk.
Thank you, Akshay, for the great presentation. I'll share my slide with you and just tell me if it doesn't work. So thank you for being here. It's a talk that I prepare with one of my colleagues, Dr. Lapierre, and I will talk mainly about the pediatric lung. So let's start. So I don't have any conflict of interest. So I have a big learning objectives today. I'm sorry for my English. This is not my primary language, so you'll have to live with my accent. So I have a big thing. Maybe we have to split in two, so we'll see at the end of the talk what we will have the time to do. So we will talk the pediatric technique and specificities, neonatal lung, because it's a chapter by itself, lung infection, because it's a big chapter in children, foreign bodies that you'd never want to miss. Asthma will had a big part on congenital lung malformation, and then the hypoplasia spectrum, and then after we'll pass sometimes with the masses and vascular malformation. So the technique. In children, it's hard to have a real good PA upright view that you do in adults. So usually we have an AP view. This is a patient in the operating room, but even though it's a 3-year-old, usually it's a PA. So your lung magnification will be a bit the heart will be a bit bigger. In the small children, you can have up to 0.6 of a cardiothoracic ratio, and instead of 0.5 for older children and adults. But it's not a good thing, but as a rule of thumb, you can expect a bit bigger heart on that kind of views, especially in neonates. The technique is super important too, because children, especially the young ones, cannot hold their breath. So it's important for the technologists to have a good inspiration. So they basically look at them cry or breathe and then try to take the picture while they inspire. So in children under 3 years old, you can expect to have 8 ribs, posterior ribs. From 3 to 7 years old, 9 and older than 7 years old, you can expect to have 10 ribs, posterior ribs. So this is an example of a kid that you have a expiration and an inspiration in the same time. So this is what can look a lung that it's not good, well inflated. The thymus. The thymus is a normal structure in the anterior mediastinum. It's a structure that is soft. You can see the vessels passing through. It can sit on the scissor doing the sail sign, like a sail. And it doesn't move anything else. So the trachea will still be at this normal place, so no mass effect. And you can still have like those little curves here that when the thymus is, is on the ribs, it can have those little curves. So it's basically a soft structure that doesn't compress anything else. So there's pediatric specificities about lungs. So the smaller bronchioles are proportionally smaller than in an adult. So you have smaller bronchioles. You know that regular lungs have collateral ventilation, which is less developed in kids. And you have a bit more resistance in the periphery of the lungs than in central lungs in the kids. And they have a bit more mucus secretions, which can lead to ventilatory consequences like air trapping or atelectasis. So kids are not small adults. Here is the baby in the NICU, and you see here that little line here, it's a skin fold. So it's not a pneumothorax in that case, but it's a skin fold. So sometimes when you have tiny little babies, those skin folds can appear to your x-rays. So for the neonatal radiograph of the lung, I basically separated them in two categories. So you have the full-term delivery, which you can have the transient tachypnea of the newborn, meconium aspiration syndrome, spontaneous pneumothorax, neonatal pneumonia, and you have your congenital malformations like diaphragmatic hernia that you can have still in prematurity, but usually it's a full-term delivery. For prematurity, you have the neonatal respiratory distress syndrome, formerly known as the hyaline membrane disease. And later on, you can develop a bronchopulmonary dysplasia. So the transient tachypnea of the newborn is the most common cause of respiratory distress in a full-term newborn. It's basically a delay in excretion of the pulmonary fetal liquid. It usually improves with treatment of support 48 to 72 hours. The risk factors are the C-section before labor, fetal hypotonia for whatever reason, neonatal sedation, maternal diabetes, and delivery before 38 weeks of gestation. So under X-ray, you basically add a perihilar edema with a streakiness of the hilar regions. You can have, which we don't see here, but fluid in the fissures, minimally increased lung volume or normal lung volumes, mild or normal heart. So you can have a mild cardiomegaly, but not that big. And rarely you can have ground glass opacities. The meconium aspiration syndrome is basically a pneumonitis, a chemical pneumonitis from the meconium and an obstruction by the meconium. So you have an hyperinflated lungs with ventilatory abnormalities and asymmetric. So you have patchy asymmetric pulmonary opacities, and in 10 to 40% of those babies, you can have a pneumothorax or even a mediastinum. Pleural effusion you can have, but it's less frequent, and you have air trapping and atelectasis. So the neonatal pneumothorax, it's a little baby in a few hours of life and then 1 day of life. So the neonatal pneumothorax, I'm sorry for the mistake of the P. It's a pneumothorax, not a pneumothorax, I'm sorry. So it can happen while the baby has a meconium aspiration syndrome, or it can happen, by itself. Usually the pediatrician won't be able to hear the heart on that side. So you can have displacement of the mediastinum of the contralateral and the deep sulcus sign here, which is the pneumothorax, the air that gets in the anterior part of the chest because the baby is lying down. So you have those deep sulcus sign here and the mediastinum that is shifted towards the contralateral side. So neonatal pneumonia. So it's basically a lower respiratory tract infection in less than 28 days of life of a newborn. The frequent agents are the Streptococcus group B, which is a vertical transmission, and that's why pregnant women get screened on the third trimester to make sure that if they are carriers of that Streptococcus, they can be treated before delivery. And you can have chlamydia, herpes, or usually those kind of things that can give the lungs, the baby, a pneumonia. It's a spectrum of the abnormalities, so you can have granular opacities, patchy opacities, and you can also have pleural effusion. So here you have a baby with those patchy here opacities on the bases and on the middle lobe. Diaphragmatic hernia are congenital defects in the diaphragm in which abdominal viscera and or organs gets into the thorax antenatally. So it's a prenatal diagnosis. Unless they're super small, but usually we diagnose them before delivery. It's more frequent on the left, and it have secondary pulmonary lung hypoplasia. So the ipsilateral lung is super small, but the contralateral lung can be small too because of the shifted mediastinum towards the pregnancy. And it's cases which the prognosis is hard to make even before delivery and after because we have some criteria, but babies do what they want. Sometimes the lung hypertension is super high, so it's hard to have a good prognosis antenatally. So let's shift to the premature baby. So the respiratory distress syndrome. So you know from your medical course that type 2 pneumocytes secrete surfactant, and they start to secrete it from 23 weeks and it matures up to 35 weeks. So the surfactant basically lowers the surface tension of the lungs, which increases compliance. So when you are born prematurely, you have less surfactant, which decreases compliance and make you prone to atelectasis and alveolar damage. So you have small lung volumes, and bilateral granular opacities like this baby here, where you can see that haziness, and you can even have some bronchograms there. On the long run, you can have serious complication of preterm birth, which up to 40% of children born before 29 weeks can have. So it's a clinical diagnosis criteria, which, how long the baby will need to have oxygen supply or non-invasive lung assistance. So it's a clinical diagnosis, but as a radiologist, you will see a lot of those babies with ill reticular markings, with rounded lucent areas, which atelectasis, cyst and lung hyperinflation. In that baby, you can see that he has a clip from a clipped arterial canal with the baby. The premature babies can have the canal can still be open because of the hypoxemia, and they try to close it with non-steroid anti-inflammatories, but sometimes they cannot get it to it. So a couple of those baby needs to have a heart surgery to close that canal. So you can have that thing here. And you see here that they go from a left thoracotomy. So you can see the ribs here are a bit wider. Okay, let's continue to pneumonia in pediatrics. So what's the definition of a pneumonia? So it's an acute inflammation of lungs caused by microbial pathogens. I don't have the incidence around the world, but in North America, it's a bit more common in less than 5-year-old children than in older children, but it's still a common infection. So higher incidence in developing or emergent countries, basically because of vaccinal issues. So there's a big vaccinal impact by the Haemophilus influenzae, which is now give to every children. So that kind of infection almost disappear as a cause of pneumonia in adequately covered countries. And the admission rate for less than 5-year-old children with pneumonia has decreased a lot with that vaccine. Mainly in infants and preschool age children, it's viruses. But viruses are rarely the only cause of pneumonia in older children if we make influenza apart, because influenza by itself can have a pneumonia. There's a lot of bacteria that can cause pneumonia. One of the most frequent are Streptococcus pneumoniae, Streptococcus of group A, less common, Staphylococcus you can have, and Haemophilus influenzae, not the type B that is in the vaccine. And you certainly can have Mycoplasma and Chlamydophilia pneumoniae in older children of 5 years old or more. We had I can't say not a pandemic, but an epidemic of Mycoplasma like 2 autumns at the autumn of 2024. It was awful. A lot of children had that. I'm sorry. Okay, so who needs an investigation when you suspected a pneumonia? So from the ACR appropriateness criteria in the immunocompetent child, usually you can rely on your clinical, and usually the chest x-ray is not appropriate, but that's not what we do. So what's the rationale? They say that it's impossible to differentiate bacterial from viral pneumonia on an x-ray, which is true. And usually there is no clinical impact on the outcome if you do or you don't do the x-ray. But in reality, the guidelines adherence are variable. If you're a junior staff, a senior staff, what's the vaccinal status of your child? What's the vaccinal status of your community? What's the season of the year? Where are you? So the guidelines are more of a help than a directive. So in a UK audit, they search, so do the pediatrician or the primary care physician do the x-ray or not? But almost all do the x-ray. So in clinic, what we do. Pneumonia is hard to diagnose mainly just on the auscultation in children. So if you have an infiltrate on the chest x-ray, it may justify an antibiotic. So that's basically the rationale underlying ordering a chest x-ray for our pediatrician. So so I want you to make your diagnosis in your head, and I will show it to you, okay? So you have to work a little bit, even though I'm talking. So it's an 18-month-old boy with fever, no cough. So it's a tricky one if you just have the AP view, because sometimes those posterior and superiodorsal segment of the left lower lung, basically, you can have a pneumonia. And if you just do the frontal view, you can see that you have opacities in retrocardiac place, but it's a bit harder to see. So the lateral view helps you to see the pneumonia. Here you have a 31-month-old with fever and cough. So basically, you have probably some peribronchitis, maybe a bit of atelectasis, but not that much. And your baby is coming back a couple of days later, and then you see here pneumonia with atelectasis, probably in the interior part of the left upper segment. So who needs a supplementary investigation? So who needs more than just an x-ray? So you can do another x-ray, especially if you have an unfavorable clinical outcome, like if the baby or the children doesn't get better, if you suspect some complication or some other diagnosis or cause for the symptoms of that patient. So here you have a children that comes to the ER, first radiograph, not that much, but 24 hours later, you see that radiological delay in the pneumonia that was probably starting there. So the baby come back really worse, so they do it again. Who needs a follow-up? The round pneumonia needs a follow-up because you want to make sure that it's not a mass. The complicated pneumonia, so the one with necrosis, abscesses, or pleural effusion. And if you have many times a pneumonia in the same localization. So what are the complications of a pneumonia? You can basically separate them in two. So the parenchyma ones, which is basically necrosis and cavitary necrosis, which can lead to abscesses and even to bronchopleural fistula, which is not good. And you can have those pleural complication. You can have the parapneumonic effusion, and you can have an empyema, which is more an infected effusion. It's low, but it's mostly in your hospitalized patient that you'll see those complications. So who is at risk of complication? So the underlying lung disease like bronchiectasis, or in our population, we have cystic fibrosis a lot in Canada. And you have anybody with a malformation, cyst, sequestrum, whatever you think of, abnormal neurological state, so they cannot excrete, they do not breathe regularly, and immunodeficiencies. So what do we do to assess those complications? So if you need more than just an X-ray and you suspect a pleural complication, the ultrasound is the good thing to do. If you suspect you have an unfavorable evolution and a non-contributive X-ray, you can order a CT scan, or to assess is my air fluid level is in the lung or it's in the pleura. So the chest X-ray, we order them only to problem-solving cases, so we don't do it on a regular basis, but usually it helps for kids with huge complications. So here we have a baby. It's not a baby, it's I don't remember the age, but it's a children with a pneumonia, and you see the pleural effusion here, that it's basically on the axillary part, doesn't seem to go on the lower parts of the lung with the pneumonia here. So on the ultrasound, you see the septa and the echogenic pleural effusion, which was an empyema. Here you have a baby, a children with pneumonia on the left side, which he had pleural effusion and a drain put there. Afterwards, after the drain was gone, you see a air fluid level on the left lower part, and we didn't know, was it just in the pleural compartment because of the drain, or it was inside the lung. So we did an ultrasound, we did a chest X-ray, sorry. So you see those cavitation here inside the lung. So it's the necrosis of the left lower lung on the pneumonia. Here you have children with clinical deterioration from that big pneumonia and pleural effusion, and 24 hours later, basically a white lung with shift of the mediastinum on the left. So he had a drain because you see air here in the pleural part, but you see that it was a necrotizing pneumonia with all those necrotizing parts of the lung, which is completely consolidated. So you have a 4-year-old with respiratory distress and fever. So at the arrival of the kid at the ER, you see that big pneumonia, opacities in retrocardiac and pleural effusion. And 24 hours later in the ICU, you see that the pleural effusion gets bigger. and you can see that the opacities on the right side get worse too. So he had a drain and no significant clinical improvement with IV antibiotics. And we did an ultrasound to see what was the part of the empyema. So here you see that the empyema is really heterogeneous, and you see too that the lung is completely filled with fluid with some part of necrosis. And that same kid had a CT, which shows a necrotizing pneumonia with those with the air fluid level in the lung, with those which was abscesses and the empyema around the lung. You have a 2-year-old kid with a persistent fever that came to the ER with cough. On the first ultrasound, you see those multiple air fluid levels in the right upper lobe. And on the ultrasound, you can see that big necrotizing pneumonia, you can call it abscess, inside the lung. Here is, again, a 10-year-old with fever and cough and wants to rule out a pneumonia. So you basically have big opacities on the left, big opacities on the right, and a huge pleural effusion, which was already septated and completely echogenic, which was an empyema on the right side. Okay, so not every pneumonia is a pneumonia. You have a 1-year-old kid with several days of respiratory distress, no fever, but transfer in our center for pneumonia and empyema. So I make your attention on the right part of the lung. You see that pleural effusion, but you see here that you have a rib that is missed, okay? You have destruction of a rib, and you have the mediastinum that is shifted on the left. So it's not normal to have something that affects your ribs just for pneumonia. So we did a chest X-ray suspecting something else. We did an ultrasound too because I don't remember, but the emergency doctor wanted to see the part of the abnormality that was lung effusion. So you see that effusion here, but you see that big mass in the lung, and it was a mass coming from the rib, which was taking almost all the right chest. So it was an Askin tumor, which is a kind of Ewing sarcoma from the rib. Another 1-year-old with fever and cough. We thought that the right part here of the mediastinum was enlarged, mainly in the anterior and maybe middle part of the mediastinum. We were not convinced that it was a pneumonia. So the kid had a further investigation with an ultrasound and with a chest CT. So at the ultrasound, you see a complex mass with cysts and septa that were thick. And on the chest CT, you see that mass here, which has some, I don't show it to you, but there was some fat in there and with some calcification, which was a teratoma. Okay, so you have a 2-year-old with cough and no relevant history. On the first X-ray, you see that hyperinflated and radiotransparent right lung compared to the left lung. In those cases, you have to suspect air trapping, and mainly in that year, in that range of years, you can suspect a foreign body. So the kid was able to do an expiratory X-ray. So you see that when the kid expires, the left lung is collapsing well, but not the right lung, which is air trapping. And he had a foreign body in the right main stem bronchus. Here's another case of a foreign body that we didn't know at the beginning. So she was, I don't know, 2 to 3 years old. She was treated for pneumonia in February, and then she came regular antibiotic course, and she gets well, but not that much, and she come back like 2 months later with that kind of lung, which is almost white with those air spaces here. And we did a scan because it was clear from the history at that time that she had choked on a popcorn, which the parents didn't know on the first x-ray. So you see that the popcorn here, and you see the post-obstructive bronchiectasis and the completed opacities of the lung, which she gets better a couple of months later. So take care of the foreign bodies. So we have a kid here with a 10-month-old with choking on a piece of paper. It was a bit atypical because you had opacities on the posterior part of the right upper lobe. You had opacities in the middle lobe, and it was not clear for us. It was an other center. And then they did the left and right decubitus to see if there was air trapping, and they thought that there was probably some air trapping on the right side because the lung was not collapsing well on the right side. So she was transferred to our center. And the transfer, which was 5 days later, you see those opacity that was around about the same, but we had a suspected adenopathies here around the hilum on the bilateral sides. So she was not doing better with regular antibiotics. Bronchoscopy didn't show any foreign bodies. So we did the chest CT, and we saw those adenopathies with central hypodensities and that complete infiltrates of the right upper lobe, which happened to be a tuberculosis. And this is her mother that was technically asymptomatic, but you can see that she has those cavitation in the upper part of the lung. So her mother was positive for tuberculosis. So time to follow up. So who are we follow up? Most of the time, kids get better, regular pneumonia acquired in community with no complications. You don't need any follow-up. So we don't recommend any follow-ups from, regular pneumonias, but who you need to tell the doctor to follow up. So the rounded pneumonia, as I told you earlier, are round. It's a transient aspect of a pneumonia in the time. So if you follow it quite quickly, like a week or two later, it won't be round anymore. So you'll be good to see that it's not a mass. So that kid on the follow-up was completely normal. Those complicated pneumonia, like the many ones I showed you before, you need to follow them to make sure that the lungs get cleared and that the thickening of the pleural spaces gets better and better. So it takes time, but usually they do fine. This is our kid with the abscess of the right upper part of the lung. In 2 months, completely cleared. So it's a 15-year-old girl with severe influenza of pneumonia being on the PICU for a couple of days or months. And she had basically a multilobar pneumonia from the influenza. And 1 month later, still in the PICU, we see that she has a lot of scars and coarse reticular opacities on her lung and hyperinflation on the left lung. And 2 months later, we saw that she had post-influenza bronchiectasis, and she was a bit better, but she still has those scars and those bronchiectasis 2 years post-infection. So it's a 25 months old kid, recent adoption from a foreign country, no relevant history. We don't know anything about that kid. So he comes and he coughs. So you see that there's probably some peribronchitis around the hilum, and you see those opacities at the root of the right upper lobe and in the middle lobe. And we did an follow-up X-ray, which was basically the same. So when the opacity stays and doesn't go away by time, we do the chest X-ray, and you see here that there was some bronchiectasis and some chronic atelectasis, probably post-viral, but we don't know. Okay. This is a 16-year-old girl, which she had a persistent left lower lobe atelectasis, which was treated for pneumonia, adequately treated. She take her treatment well 2 times. She doesn't have fever anymore, but she still cough. So what do you see here? So you see a complete atelectasis of the left lower lump with a little bump here. So it was weird to have a bump there. And in the context that it was a persistent atelectasis on the same lobe, we did a chest X-ray, which was we were seeing that the left lower lobe were completely collapsed with liquid-filled bronchis. And you see a mass here with a calcification here at the left hilum, which was a carcinoid tumor, which was obstructing the left main bronchus. And she had she had a surgery. They resected the mass and the left lower lung. Okay, so move to asthma. So it's a 6-year-old boy or girl with dyspnea and coughing a lot, no fever. He arrives at the emergency room, so put on a treatment with Ventolin and oxygen. So you see here that there was some opacities, probably more atelectasis because of it was a bit not that thick on the lateral view. And you see here air filling the interior mediastinum and the middle mediastinum here. So you see the pneumomediastinum with the subcutaneous emphysema. So asthma can give pneumomediastinum, atelectasis, and subcutaneous emphysema. It's another case which was more subtle that the clinician did saw the first time. So you have basically your normal lung, maybe with some peribronchitis, but you see here those little lines on the left side and maybe 1 or 2 on the right side, which was the pneumomediastinum with the asthma. Usually it goes away by itself. Okay, just let me see the hour. Okay, we're good. So we'll talk about pulmonary development and some of the abnormalities that can happen in the baby's lungs. So basically, the airway starts about a month of embryonic stage and continues almost to 36 weeks with the bronchi first, and then bronchioles, and then the respiratory bronchioles, and then the alveoli. When the baby is in the mother's abdomen, the baby is surrounded by fluid, and the fluid is super important for the development of the normal lung. So the baby and the amniotic fluid share the liquid to make sure that the fetal lungs are growing well. So there's many things that can go wrong in that part. So you have to have a normal thorax of the baby in volume and shape. So some skeletal dysplasia that have really, really small thorax, the lungs of the baby cannot develop well. So you have to have normal amniotic and lung fluids. So if there's no amniotic fluid, all basic, as an example, if you have no kidneys of the baby, so you have no fluid, so you have no amniotic fluids, you cannot grow your lungs, so you'll have lung hypoplasia. And the baby have to move and breathe in and breathe out to make sure that the lungs get all the fluid that they need. So all of those issues that can go wrong during pregnancy can lead to pulmonary hypoplasia. Okay, so we have a spectrum of pulmonary malformation, and obstetrical images are essential if available. We have an increases incidence of reported pulmonary malformation since the prenatal diagnosis. So the major part of our pulmonary malformation are detected prenatally. And there's a lot of confusion in terminology and treatment. There's 4 big categories. The bronchial atresia and air trapping, which was a bit before congenital lung emphysema, known as congenital lung emphysema before. You have the CPAM. You have the pulmonary lung sequestration. You have bronchogenesis, and you can have an hybrid of usually CPAM and sequestration. So it's a spectrum more than separate entities, and hybrid lesions are super frequent. So let's start with air trapping. So bronchial trapping lesion, which is usually from bronchial atresia. It's 1 on 100,000 birds. So the etiology, you can have obstruction, compression, or atresia of a bronchi. It's more frequent that you can expect, but there's rarely associated malformation on the fetus. What do you see in fetal ultrasound? So you see here an hyperechogenic lesion in the lung, which is homogeneous, mostly on the superior lobes, but can affect more than one lobe. Here you see that little dot in the center, which is filled with fluid, which is a bronchocele. And usually it does a mass effect on the mediastinum. So you have another example here of a bronchial atresia with the hyperechogenic part of the lung here on the right side, with slight deviation of the mediastinum to the left. At 2 days of life, you see that the baby has a bit of delay in excretion of the fluid in that part here. And at 17 months old, you see that hyperinflated lung with you can still see the vascular marking. So it's not a cyst, it's a air trapping lesion with the bronchocele filled with fluid. So here at 19 weeks of pregnancy, you have a big left upper lung mass here. At 22 weeks, it's still there, still big. And during the pregnancy, you still see the mass, but the mass effect itself is better. So it didn't grow as fast as the baby. So it's not gone, but it's better than it was at 19 weeks, which is usually what we see. You see it really big early on in the pregnancy, that it gets usually a bit better during the pregnancy. So you see here that baby on day 1, you see that the mediastinum is shifted on the right with some delay in excretion of the fluid here. On day 2, you still have a lot of fluid in that lung, because when you have the trapping lesion, it's long for that lung to clear the fluid. And at 6 months old, you see that part was filled with fluid is now filled with air. And you see here that lesion, which is a trapping lesion. And in that particular case, we were suspecting something that was compressing the lingula, which was a bronchocele compressing the lingula and was doing the trapping lesion. So what's a CPAM? CPAM is a malformation of the lung. It's quite rare, but there's a lot of classification. The Langston classification is a pathological description, and it's usually a 2nd trimester diagnosis. If you have a good 2nd trimester ultrasound that shows no cyst at all, and it's a new lesion on the 3rd trimester or on a newborn, you have to think tumor like a pleural pulmonary blastoma or a flit. Usually the CPAM are there at the second trimester, so at the first ultrasound at 20 weeks, you see it. The Stalker classification is a classification for the congenital pulmonary airway malformation. Basically, we see the type 1 and the type 2s. The type 1 are larger cysts, and the type 2 are smaller cysts. I never see any type 0. It's incompatible with life. And those we see really, really rarely. So basically, as a type 1 or a type 2 based on the size of the cyst. So here you have an example of a big mass, which was mixed hyperechoic and hypoechoic, which was shifting the mediastinum on the contralateral size. It's usually unilateral and usually unilobar, and you can have eye drops. It's not frequent, but you can have eye drops, and you can have some associated abnormalities like cardiac, kidneys, or tracheoesophageal abnormalities. It's a good survival rate without eye drops, and if it's really huge, you can do a shunt to drain a bit of the fluid in the pregnancy, but you have to have a baby that has eye drops and is really, really, really bad. So here are another example of a CPAM. At 20 weeks, you see a lesion filled with cyst and a bit heterogeneous that was shifting the mediastinum. And you can still see it at 23 weeks and 27 weeks, but you see that the mass is a bit smaller than it was at 20 weeks. The CT scan was done at 50 days of life, and you see that CPAM, which a lot of cyst here on the right lower lobe. So what's the natural history of sequestration and CPAM? More than half of the diagnosed sequestration and CPAM during the pregnancy will get smaller at the third trimester. A quarter of those lesions will be undetectable late in gestation, and about 20% will develop symptoms after the neonatal period. Most of them, 81%, will remain asymptomatic. So what are the complications? So prenatal complications can be polyhydramnios, eye drops, and the postnatal complications can be infection, respiratory distress, and the malignancy risk is debated, but it's only associated to CPAM, not to sequestration. And the management is super controversial. So the management of those lesions, especially the CPAMs, are variable wherever you practice. In the US, usually they operate them at 6 months of age, but there's some places like Great Ormond Street in London that mostly follow them, and they have really strict criteria to operate them or not. In our institution, we had meetings with radiology, pneumology, and surgery, and we came up with a follow-up. It's in French, but it's just for the concept. We have a follow-up that is mainly written on, and we see we know each baby discusses it in multidisciplinary themes. So basically, it's usually each places as their teams, and they discuss all those babies. In our institution, which is not the gold standard, but it's our institution, prenatally, they see obstetrics, genetics, surgery, and radiology. And depending on the shift of the mediastinum, eye drops, polyhydramnios, size of the lesion, they can or cannot do an intervention prenatally. And then postnatally, they get a chest X-ray at birth. And depending on the size of the lesion, the obstetrician decided before delivery if the baby will be delivered in the tertiary center or in the local center. So depending on what we see on the chest X-ray, the baby can be operated on really rarely if it's super big. And usually in the first 6 months of life, they're followed by surgery and pneumology. and they get a CT scan around 3 to 6 months of age, or earlier if they have risk factor for a tumor. And if they are at risk for a pulmonary blastoma, they get a Dicer 1. After that, if depending on the Dicer 1 results, and usually they get another CT 12 months after the first one, and then the next CT will be around 5 years old. And they always have a follow-up in surgery and pneumology. And depending on the size, if they had infection, if the Dicer 1 is positive, they can or cannot be operated on. But it's mostly a multidisciplinary decision. And it's super controversial. So probably in all your centers, it's different. So be careful. It's a second trimester diagnosis. If it's a new lesion, you cannot assume that it's a CPAM. So think tumor. Sequestration. What's a sequestration? It's a more or less functional pulmonary parenchyma that is that the vasculature is come from a systemic artery, usually from the descending aorta. So in that case, you see a hyperechoic left lower lung lesion. Here you can see it on the angio, which is not the standard of care, but in an old case, you see that vessel from the aorta that vascularized the left lower lung. So the sequestration is one of 15,000 births. There's two types, the intralobar and the extralobar. So the extralobar is surrounded by pleura, and from a radiological part of view, usually it's drained by a systemic vein. And the intralobar one, which is the most frequent, usually is drained by a pulmonary vein. So on the ultrasound, you can see a left lower lobe lesion, which is hyperechoic, and usually in prenatally, you can see the vessel from the aorta. There can be associated abnormalities, especially in the extralobar ones, around 50%. So the cardiac, vertebral, diaphragmatic hernias can be associated to sequestration, and they may regress. They may regress. At the third trimester. So it's an example of extralobar sequestration here. So you see that left lower lobe hyperechoic lesion here at 20 weeks, which was vascularized by a vessel from the aorta. And here at birth, you see that big vessel coming to the sequestrum. And here you see the systemic vein going in the azygos. So it was an extralobar pulmonary sequestration. This is an example of an intralobar one. So that big lesion here on the right lower lung, which was vascularized by the aorta, and the pulmonary return was in the left auricle, which was pulmonary venous return. We have a lot of IRIL lesions. So here it's a intralobar sequestration with some part of cyst here. So you have that big lesion, heterogenic with cyst and with hyperechoic part, with a vasculature from the aorta, vascular return pulmonary. So here, postnatally, you see that there's cyst. It's the CPAM part. And I don't show it well, but there was an artery from the aorta, which was the sequestration part. We have here a bronchogenous cyst. So it's a malformation of the bronchial tree. It's a form of foregut duplication cyst, which is lined by a respiratory epithelium. And there is usually a communication with the airway. So the cyst can be air-filled or liquid-filled. It's usually on the 70% on the middle mediastinum, and less frequently can be in the pulmonary parenchyma. So here you have that mass here, in the let's say in between the middle and the posterior mediastinum, which was completely cystic in the MR, which was a bronchogenic cyst. So actually, it's I'm almost, let me see. No, I'm not done. Do you want me to continue on the mediastinal masses and on the pulmonary spectrum of hypoplasia in another part? Actually? Okay, I see. Yes, ma'am, probably. Yeah, would be a good thing. Let me see if there's any questions.
Hi, sorry. I think I was unmuted. I was
Okay,
muted.
it's okay.
Yeah, no, I think it's great. It's a good idea to take a second one.
Okay.
The session was phenomenal. You showed really interesting cases, and we would rather have you take them in more detail than rush through them, if that works for you.
Okay. Is there any questions for me?